Hey everyone, and welcome to our explainer. Today, we're diving deep into asthma. It's a condition that affects millions of people, and it can turn something we all take for granted, just breathing, into a real challenge.
To really understand what this feels like, I want you to try a little something right now. Go ahead, take the biggest, deepest breath you possibly can. Fill your lungs all the way to the top, and hold it right there. Okay, now, without letting any air out, try to take another deep breath on top of that one. That feeling, that pressure, that sensation of being completely full with no more room to expand, that's what it can feel like to have asthma. It's a really powerful way to get a sense of that struggle.
So here's the roadmap for today. We're going to start with what asthma actually feels like, the symptoms. Then we'll get into the science, this thing called the airway obstruction triad. After that, we'll see how doctors lock in a diagnosis, walk through the step-by-step treatment plan, and finally, cover what happens when things get serious and it becomes an emergency.
All right, so let's kick things off with the basics. What are the common signs that make someone think, maybe I should get this checked out?
Well, the complaints usually boil down to a few key things. First, there's dyspnea, which is really just the medical term for feeling short of breath. Then you've got wheezing, that classic high-pitched whistling sound when you breathe out. That's the sound of air trying to squeeze through tiny, narrow airways. There's also often a nagging cough, all thanks to that underlying inflammation. And something a doctor might notice is hyperresonance, a deep booming sound if they tap on the chest, which is a dead giveaway that air is getting trapped inside.
So, what's actually causing all of this? Well, it's not just one thing. It's more like a perfect storm of three things happening all at once inside your lungs. We call it the airway obstruction triad.
So let's get into it. What is going on deep inside those airways that makes the simple act of breathing so incredibly hard? It's this three-part problem.
Part 1 of the triad is bronchial wall edema. Basically, your airways get super inflamed and swollen. Just imagine a water pipe suddenly getting narrower on the inside. Right away, it's going to be a lot harder for anything to flow through it.
Okay, part 2, excess mucus. All that inflammation sends a signal to these little things called goblet cells, telling them to go into overdrive. They start pumping out tons of thick, sticky mucus. So now, our already narrow pipe isn't just narrow, it's also getting clogged up with gunk. And the final piece of the puzzle is bronchospasm. There's a smooth muscle that's wrapped around all of your airways, and during an asthma attack, that muscle just contracts and clamps down hard. It's this incredibly powerful squeeze that can almost completely choke off the airflow. So you've got swelling, mucus, and muscle squeeze all at the same time. No wonder it's hard to breathe.
And the result of this whole triad? Something called air trapping. See, because of all that obstruction, it becomes way harder to get air out of your lungs than it is to get it in. So old, stale air gets trapped, causing the lungs to overinflate. And that brings us right back to that feeling we started with, your lungs feeling totally full, with no room left to take a fresh breath.
So you have the symptoms, you understand the cause, but how do doctors know for sure that it's asthma? This is where they have to move beyond just symptoms and get some real objective proof. The main tool here is something called a pulmonary function test, or PFT. What they're looking at is a special ratio. The amount of air you can blast out in 1 second, that's your FEV1, compared to the total amount of air you can possibly breathe out, your FEC. If that ratio drops below 70%, it's a big red flag for some kind of obstructive lung disease.
But here's the thing. Obstructive lung disease is a pretty broad category. It could be a few different things. The key question, the one that really points towards asthma, is this. Is the obstruction reversible? Can we make it go away?
And this is the magic number. Here's what they do. After you do the first test, they give you a puff of a bronchodilator, a medicine like Albuterol that opens up the airways. Then you do the test again. If your FEV1, that amount of air you can force out in 1 second, improves by more than 12%, bam! That's a huge sign that the obstruction is reversible. And that reversibility is the absolute hallmark of asthma.
All right, so the diagnosis is confirmed. Now the focus completely shifts to management. And the good news is, there's a really well-established step-by-step approach to keep things under control.
Before you even start treatment, you have to know how severe the asthma is. And there's a super simple way to think about this called the rule of twos. Just ask yourself, are you having symptoms during the day more than twice a week? Are you waking up at night with symptoms more than twice a month? Have you had more than 2 big attacks in your entire life? If the answer is yes to any of those, you've likely got what's called persistent asthma, and that means you need a daily medication to control it, not just a rescue inhaler for emergencies.
And that leads us to the treatment ladder. It's a really logical stepwise approach. If your asthma is mild and only pops up now and then, you're at step 1, just using a rescue inhaler as needed. But if it's persistent, you move to step 2, adding a daily low-dose steroid inhaler to tackle that inflammation. If that's still not cutting it, you climb to the next step, maybe upping the steroid dose or adding another type of medication. The whole idea is to find the lowest possible step on the ladder that keeps your symptoms in check, and you only climb higher when you absolutely have to.
Now, it is so important to understand this. Your daily routine for managing asthma is one thing. A severe, life-threatening asthma attack is a completely different animal. When things go bad, the playbook gets thrown out, and the treatments change in a big way.
Just look at the difference here. Daily management is all about long-term control of inflammation, using things like inhaled steroids. But in an emergency, the one and only goal is to open up those airways right now. That means pulling out the big guns, aggressive treatments like duonabs, IV magnesium to help relax those clamped-down muscles, and powerful systemic steroids to knock down that massive inflammation. Sometimes you even need breathing support from a machine like a BiPAP.
And you have to know the warning signs that an attack is becoming a true crisis. You might see someone using their neck and chest muscles just to gasp for air. But you know the most dangerous sign of all is actually a silent chest. You think hearing no wheezing is a good thing, right? Wrong. It can mean the airways are so tight that not enough air is moving to even make a sound. That is a terrifying sign and a full-blown medical emergency.
So here's the bottom line. Asthma is a chronic condition, there's no doubt about it. But for most people, it is absolutely manageable. The path from diagnosis to treatment is clear. The real key, the most important takeaway, is knowing your own body, knowing what triggers your symptoms, and knowing your treatment plan inside and out. That knowledge is what empowers you to take control. Thanks for tuning in.